Hello class, today we'll be talking about the axilla and the brachial plexus. So the axilla and brachial plexus are really important for upper extremity function. There's a lot of lesions that can take place in the axilla and as well as within the brachial plexus, which is a set of nerves that carry signals to and from the arm and to and from the scapular region. Some of those nerves we've already seen. So extremely important to examine the brachial plexus, know the brachial plexus inside and out so that when lesions do occur, we can figure out what the deficits might be. So for this slide, I wanted to offer a video, unfortunately, of me because I wanted to show you kind of where the axilla is in relationship to the body. Here we see a picture of the axilla, and we have the beginning of the axilla this way and the end of the axilla this way. But sometimes that doesn't mean much to a student or someone learning this. So if you take your right hand and you grab the middle of your clavicle and you go posterior to that clavicle, there's a very soft spot, and it's very sensitive when you put pressure down into it. Keep that right hand on that right soft tissue behind the clavicle, and take your left hand, left finger, put it up in your armpit. Imagine your fingertips were connecting. The connection there between one fingertip to the other fingertip is the axilla, and we have a lot of important structures running through that region to carry things into your arm or from your arm, specifically blood and also motor signals. Okay, so as you notice, we took the video off. So what you see here again is the axilla colored in green, and we have the entryway into the axilla, just posterior to the clavicle, just anterior to the first rib. Of course, have a rib cage over here that's forming the medial wall, as well as any of those muscles that are attached to the rib cage, primarily a muscle called the serratus anterior. Laterally, we have the humerus, specifically the intertubercular sulcus of the humerus. Anteriorly, we have a set of muscles, the pectoralis major, the pectoralis minor. Above, we have a little small muscle called the subclavius and some fascia as well. And then we have a posterior wall. The posterior wall is quite hard to appreciate here, but you can imagine that there's a scapula somewhere back there. So it's all those muscles that we've already learned. But the anterior portion of the scapula, or anything coming off the lateral border of the scapula that's most anterior. So we have the subscapularis, the teres major, the lat, and that long head of the triceps. So most of those muscles should look familiar at this point, and several of them are helping to form that quadrangular space that we saw posteriorly. But now kind of go to the anterior side of that quadrangular space, and we have the posterior wall of the axilla. So here in this slide, it's a bit redundant, but as you can see now, we can see the posterior wall with the scapula here and those muscles that would attach to it. We have the anterior wall on the bottom picture, basically the big pectoralis major coming off over here. And that's basically the anterior and posterior wall, as we like to think about it. I think we have a decent understanding now of where that axilla is. Let's talk about some specifics of these structures that maybe we haven't seen yet. So here we have a great picture of the pectoralis major muscle. So as you can see, the pectoralis major extends from very medial here against the sternum. Here we're against the manubrial part of the sternum. And then we have a large portion of the clavicle. And we like to say it's really the medial third, but that often can extend out to the medial 1/2 of the clavicle. That the clavicular portion, so this is the clavicular portion, and this is the, sorry about that, that should be an S. and that's the sternal portion. So we have the clavicular portion of the pectoralis major and the sternal portion. And obviously the clavicular one comes from the clavicle and the sternal one part comes from the sternum. But this sternal part is quite large and it extends down, has some rib attachments or costal attachments. And this very large pectoralis major extends out and inserts onto the medial or anterior medial humerus. So you can imagine if the arm's by your side and this pectoralis major contracts, pull that way, and can help to finish some more adduction of the humerus at the shoulder. Can also internally rotate the humerus at the shoulder, so it's going to spin it if it was in this resting position, this neutral resting position as we see here in this picture. But in addition to adducting and internally rotating, certainly if the arm was fully flexed, like you see here, it's flexed. If the person wanted to now extend their arm, the pec muscle will help to extend the arm. Or if the muscle, it's hard to appreciate in this picture, but imagine this person here is extended already, their arm is behind them, and they now wanted to bring it forward. The clavicular portion would help pull the humerus forward. Okay, so what can the pectoralis major do? Well, it can adduct, it can internally rotate, it can extend, it can flex. I don't think it can abduct, and it shouldn't be able to externally rotate unless maybe perhaps if the humerus was really fully internally rotated. Maybe it could have a little it could help to do the external rotation, but really it's an internal rotator and as well as the adductor, extensor, and flexor. Now let's draw our attention to the bottom here. We have the pectoralis minor. So here you see the pectoralis minor coming from, here's the first rib, second rib, third rib, fourth rib, fifth rib. So ribs 3 through 5 extends upward to hook onto the coracoid process of the scapula. So as you might imagine, if this muscle contracts, will it pull on the ribs? It certainly could try to pull on the ribs upward, so it could be an accessory breathing muscle, accessory inspiration. But more likely, it's going to pull down on the coracoid process, so we're going to anteriorly tip the scapula. So this anterior tipping of the scapula will help to help to cause protraction of the scapula. Sorry about my writing there. Protraction of the scapula as well. But more importantly, this muscle can play a role in getting in the way sometimes of some of the neurovascular structures that will be coming through this area. So we're going to take a look at those a little later on in this lecture. So here we see the subscapularis. So we've seen that before. It's sitting in the subscapular fossa. We know the teres major at this point, right? The teres major is going to be a powerful adductor. That's what this arrow is indicating. The subscapularis is going to be a powerful internal rotator. There's the adduction for the teres major. The latissimus dorsi is going to be a powerful adductor and extender. We could probably put extension in here as well. And both of these will also internally rotate the humerus at the scapula, at the shoulder joint. Medially, within the axilla, we have this serratus anterior muscle. And that serratus anterior muscle is innervated by the long thoracic nerve. Now this muscle is critically important for scapular stability. I'll repeat, this muscle is critically important for scapular stability. So it attaches anteriorly to the ribs and has a very broad attachment. Here I've drawn in, I think they might even have a first rib attachment. 1, 2, 3, 4, 5, 6, 7, 8. 9. I would say 1 to 9 rib attachments. And it's going to extend backwards and grab on to the scapula, to the anterior portion of the medial border. So way over here, I'm putting a dotted line in to indicate the medial border of the scapula, which is obscured right now. So it's kind of wrapping around all these ribs to attach onto that medial border. So you can imagine if those muscle bellies of the serratus anterior contract, it's going to pull the rib forward on the thoracic wall. It's going to pull the scapula forward on the thoracic wall, which will essentially protract the scapula, right? It will protract or abduct the scapula. But generally speaking, this muscle keeps the scapula from tipping. Okay, so although we have the pec minor, attaching over in here and attaching to the coracoid process, trying to tip the scapula. The serratus anterior is grabbing the other end of the scapula, the medial border, and is counteracting that tipping. However, together they can both help to protract or glide the scapula forward. But the tipping is being resisted by the serratus anterior muscle. So if you have a lesion of the long thoracic nerve, that equals scapular tipping, okay, which we will also call winging. So this slide contains, I just added in a picture of the winging of the scapula. So here we see usually it's the inferior tip and often the medial border will come away from the scapular wall. And we typically will find winging when we ask someone to do what's called a wall push-up. Put their hands against the wall. This looks a little high. I would normally ask them to put it a little lower than shoulder height. And as they put their weight through their arms, they have an insufficient contraction of the serratus anterior, so the medial border, which the serratus attaches to, will start to come away from the thoracic wall. On the left, we see a very nice picture of this serratus anterior muscle attaching to the medial. Well, it's hard to see that it attaches to the medial border, but you can see it's going up in front of subscapularis to attach somewhere medially, but generally the attachment point, we can see that here, the attachment point is that medial border of the scapula. Now, here's a first glimpse of what travels through the axilla. And then we have this axillary sheath, and what that really is indicating that we have a sheath of tissue that's through which is traveling the axillary artery. We're going to see that in a second. Okay, so the axillary artery, along with several nerves, are going to run through there. So here we go. What's in the axilla? Well, like I just said, we have the axillary artery, and along with it we have an axillary vein and all its branches for the arteries and the tributaries for the veins. So that's kind of a new concept here. We have arterial branches, so it's like a tree where you have a larger one and then you have little branches that come off of it. But veins have what are called tributaries. Okay, so I'm going to draw the same structure. But in this case, the blood flow is that way. That means it's a branch. But in the case of a vein, the blood flow is that way. So up here we have branches, and down here we have tributaries. What else is going through the axilla? Well, we have the brachial plexus that we're going to talk in detail about. We have portions of muscles. In other words, proximal muscles from the arm, the coracobrachialis and the biceps brachii. specifically the part of the biceps brachii that goes to the coracobrachialis, which we're going to learn that next time. But we might as well mention it here that the biceps, it's called biceps because it has two heads. The short head of the biceps goes to the coracoid process. So that'll go through the axilla. We also have some lymph nodes that we won't talk too much about in this course, but it's very good to know that they're there. They're extremely important lymph nodes in this area that can fill with lymph, obviously, but can also, when there's a breast cancer, the breast drains partially into these nodes, and therefore this is an interesting area to biopsy in case there's a suspect of cancer in the area. And then we have the axillary process of the breast. So so you can appreciate that there is breast tissue in males and females. Anytime that there is growth of that breast tissue, particularly in females, there's an axillary process. So there's an extension of the breast into the axillary region. So let's start talking more about the axillary artery. Here we see the axillary artery. It's very large, but everything we see here is not the axillary. So let's break this down a little bit further. The axillary artery starts at the lateral border of the first rib. Okay, so here I've drawn in the lateral border of the first rib. Prior to the axillary artery is the subclavian artery. Okay. Now the axillary artery continues distally until the lateral or inferior border of teres major. I'm going to draw that in blue. So that's the inferior lateral border of teres major. So between that little purple line and the blue line is the axillary artery. Distally is the brachial artery, named because the word brachial means arm. So now this vessel is in the arm at this point because it's progressed past the axilla. So now it's in the arm proper. So we have the subclavian draining into the axillary, draining into the brachial. Now the section between the purple and blue lines is the axillary, and it has three parts. And the parts are defined by the pectoralis minor. So here's one edge of pectoralis, here's the other edge of pectoralis. So this is part 1, this is part 2, this is part 3. Part 1 has one branch coming off of it. Okay, so this is part 1. The supreme thoracic artery, which helps to serve the upper thoracic area and a little bit of the upper breast as well. Part 2 is going to be situated underneath the pectoralis minor, and I'm just going to kind of draw two little black dots just to indicate roughly where the two vessels, the thoracoacromial artery and the lateral thoracic artery, come off. Really, that thoracoacromial artery is right there, and I know that doesn't look like it's under pec minor, but this is kind of a general rule or guideline, if you will. So that's the thoracoacromial, helps to serve the pectoralis major muscle, and the deltoid muscle helps to do a lot of muscular, bring blood to muscular areas. The lateral thoracic, if you recall, I just talked about the serratus anterior innervated by the long thoracic nerve. The blood supply is from the lateral thoracic artery. So that's kind of nice. They both have this kind of thoracic in the middle there, and one's long and one's lateral. The third part of the axillary artery has three vessels. So like we see here, the first part has one, the second part has two, and the third part has three. So that's nice. We have the subscapular artery, we have the anterior circumflex, and we have the posterior circumflex femoral artery. Obviously, you guys know the posterior circumflex quite well at this point, but there is a corresponding anterior circumflex artery. And here we see a little glimpse of that artery. Here we see a little glimpse of that anterior circumflex wrapping around the humerus. Thus, it's named the anterior circumflex humeral artery. And it's going to anastomose, or come together, with the posterior circumflex artery that we saw posteriorly in that quadrangular space, traveling along with what nerve? Yes, the axillary nerve. I'm just going to take a guess, a stab, to say that you guys all said the axillary nerve there. Okay, so here we are. We're at the brachial plexus. If you've heard about the brachial plexus or studied the brachial plexus in the past, perhaps you were dreading this moment. We're going to try to break this down as best as we can and get you to the point to where you at least feel somewhat comfortable with it, but it will take plenty of time on your side, on your own, drawing out the brachial plexus. You want to draw out the brachial plexus many times. I've gone through hundreds of sheets of paper. I know it's a waste of paper, but maybe you can do it online on a tablet. I've gone through hundreds of sheets of paper drawing the brachial plexus to get to the point to where I can feel very comfortable. I want you to get to that point because when there are lesions, like I said before, in the brachial plexus, you can problem solve what the presentations might be, or you can work backwards with the presentation to figure out where the lesion of the brachial plexus might be. So let's give it a start. What is the plexus? Well, it's a network of nerves. Okay. Here we see the ventral rami. So we have the ventral rami of C5, 6, 7, 8, and T1 that get redistributed. They get redistributed within the plexus, or because of the plexus, they get redistributed to then thus serve the upper extremity and the scapular region, and they bring a motor supply to that area, and they also carry the sensory signals from that area back to the spinal cord via those ventral rami. As this slide is showing, the brachial plexus originates here in the neck, passes through the axillary area, and extends through its terminal branches into the arm. Of course, we have a right-sided plexus, and we also have a left-sided plexus, mirroring each other. There are different parts of the brachial plexus, and we'll go specifically into all these parts. There are rami, or roots. There's trunks, divisions, cords, and terminal branches as well. Okay, so where can we find the brachial plexus on a human being, an undissected human being? Well, what these three pictures are showing are, we would like to find the brachial plexus somewhere in this region right there. I just drew it in green. So it's posterior to a new muscle that we just come across, the sternocleidomastoid muscle. Posterior to that, but anterior to this muscle we know and love so much now, the trapezius muscle. So it exits out of the neck within this posterior triangle before it descends into the axilla and then into the arm itself. So here are just a few pictures that show you where this posterior triangle is, what it borders. I do want you to know generally what the posterior triangle is and generally what the borders are, but more specifically, I just want you to kind of have a good idea of where this brachial plexus is emerging. What is in this posterior triangle? Well, we have lots of muscles in the posterior triangle. You're familiar with the splenius already. You've already seen the levator scapula climbing up from the scapula up into the neck. And then we have the anterior and middle scalene muscles. And these are specific neck muscles that attach to ribs and also to the vertebra. And so they help do some accessory breathing, especially inspiration, just like the pec minor. Anything that lives up on the ribs are going to help do accessory breathing for inspiration. Sorry, there should be an N in there. And then also we see this little small muscle called the omohyoid muscle. That's this diagonal muscle in here, the gray one. That's not listed in the key. And here we have the brachial plexus emerging just posterior to sternocleidomastoid in the posterior triangle. What else is in the posterior triangle besides those muscles and the brachial plexus? Well, we have that spinal accessory nerve. Well, why do we have the spinal accessory nerve? Because it innervates sternocleidomastoid. It innervates sternocleidomastoid, and of course it innervates trap. So here we see it. Draw it in blue. Here we see it traveling in this direction to innervate the sternocleidomastoid. I'm sorry, to innervate the trapezius after having innervated sternocleidomastoid. And what else do we see in the posterior triangle? We see the nerves of Erb's point. Now, you guys do not need to know all the individual names of Erb's point. There's quite a few. But just know that the nerves of Erb's point are in the posterior triangle. Okay. Here we have some specifics about sternocleidomastoid. Well, it's kind of a neat name because it tells you exactly where its attachment points are. It attaches distally to the sternum and the clavicle, thus the sternocleido, and then proximally it attaches to the mastoid. The mastoid is a bump. If you grab the back, if you palpate behind your ear, there's a bump just behind your ear. That's called the mastoid process. So it attaches to the mastoid process. And then again, like I said, it's innervated by the spinal accessory nerve. And what is this action? Well, you can imagine if you put one of your index fingers on where your sternum and clavicle meet on your SC joint, put the other one on your mastoid process, and you try to bring those 2 points together, what will you be doing? Well, you'll be side bending your neck to the same side of the muscle, but you'll be rotating away from that side while flexing the cervical spine. So cervical spine flexion, ipsilateral side bend, and contralateral rotation. Okay, a little bit more specific about the brachial plexus now. Again, it's emerging from C5 down to T1. Here we have T1 right here. So this is T1. And it's emerging out between the anterior scalene and the middle scalene. It's merging out between both of those muscles. We have C5 and C6 coming out above. They're going to ultimately merge. We have C7 coming out. These are the ventral rami. The dorsal rami are going to serve those deep neck muscles, such as splenius, semispinalis that you learned, and the posterior triangle, not the posterior triangle, the suboccipital triangle that you didn't need to learn the names of. So we have C5 and C6 coming together. That's going to form the upper trunk. We have C7 going it alone to form the middle trunk. We have C8 and T1 joining to form the lower trunk. Like I said earlier, the brachial plexus has 5 subdivisions: the roots or rami, the trunks, the divisions, the cords, and the branches. And you're going to have to go through those in your head quite quickly, and it can be confusing. So try to adopt a mnemonic. Here's a mnemonic. It's called "Real Truckers Drink Cold Beer." When I was learning the brachial plexus in 1992, the mnemonic that was floating around was Randy Travis drinks cold beer, but my guess is none of you guys, unless you really like old country music, know who Randy Travis is. So let's stick with real truckers drink cold beer. And then as we get down into the terminal branches, seen down in here, another, maybe not so reliable mnemonic, but one that can help just remember the first letters of all 5 is Marmu. Okay, Marmu. Of course, there's a few N's here, so that can get a little tricky, but this will become more clear as we go through this brachial plexus. Note that we have an axillary artery. Now, the artist is just showing the axillary artery as it pertains or as it relates to the terminal branches of the brachial plexus. But keep in mind that this axillary artery came from that subclavian and looped around in that direction. So these cords over here will be named according to their relationship to the axillary artery, while the trunks are named according to their relationship with each other. So as we start in the brachial plexus, we have a kind of a superior to inferior orientation, or an upper to lower orientation. So the first confluence of C5 and C6 will be the upper trunk. C7 continues into that middle trunk. And C8, T1 is the most inferior structure when it combines, so we call that the lower trunk. And this says more of the same. We have that C5, 6, 7, 8, 1, and C5, C6 come and form that middle trunk. C7 is middle trunk, C8 and T1 are the lower trunks. Yes, I'm repeating myself, trying to get you to hear this multiple times, so maybe it sticks a little bit. So that is generally straightforward for students. This is where now it starts to get tricky, but let's try to break it down a little bit. So we have real truckers drink cold beer. Roots, trunks, divisions, cords, and branches or terminal branches. Note that off of the upper trunk are 2 divisions. There's an anterior division shown in green and this little small posterior division. Note that the middle trunk has an anterior green division and a blue, thicker posterior division. And note that the lower trunk has an anterior division shown in green and the blue posterior division. So each trunk has an anterior and posterior division. These divisions come back together. These anterior divisions and posterior divisions come back together in some form or fashion, differently for all 3, to form these lateral, posterior, and medial cords. Again, named for their relationship to this axillary artery. The artist has not shown is not showing the axillary artery extending upwards, because if they did, you wouldn't see the posterior cord. But you could imagine as this, let me change color, as this artery extends up this way, that this posterior cord would be posterior to the axillary artery. The medial cord would be medial to the posterior to the axillary artery, and the lateral cord would be lateral to the axillary artery. Lastly, we have the terminal branches. Again, we have the mnemonic Marmu, and we have from lateral to medial, we have the musculocutaneous. We have that axillary, you know that one. We have the radial. We have the median. And we have the ulnar. All right, so this upper picture I really like. It's simple. It's somewhat simplified. However, now the artist has added in other branches besides these terminal branches. We're going to do the real truckers drink cold beer again. And so here are the terminal branches. We have the marmu. The artist has obviously taken away the axillary artery, so we don't have an artery here to show the relationships for these lateral, posterior, medial chords, but you could appreciate that this axillary artery would be shooting up through there. Okay, here we have C5, and the very first branch off of the brachial plexus that's not a terminal branch is the dorsal scapular nerve. Now you guys know the dorsal scapular nerve. What muscles is it going to? That's right, going to the levator scapula and the rhomboids. So that's where this nerve comes from. Just comes off of C5. So you can imagine what vertebral levels are contributing to the dorsal scapular nerve. Only C5 vertebral level. Going down, we have the next artery, the next nerve, the suprascapular artery. And as you can tell, the suprascapular artery comes off the upper trunk, which is formed by C5 and C6 coming together. So the suprascapular nerve, I feel like I've said artery a couple times. If I did, I apologize. The suprascapular nerve is formed by C5 and C6. We won't worry about the subclavius. It's not important for us. So we're going to cross that out. The next nerve we get to is the lateral pectoral nerve. Now, what muscle do you think that nerve might go to? It's going to help to serve the pectoralis major muscle. Pec major. Okay. And as we continue down, we have the musculocutaneous nerve. Now, if we think about how that nerve gets, where that nerve gets its nerve roots from, we could trace this back. And we could see that there was an anterior division coming off of the middle trunk, which came from C7. Obviously, the superior trunk contributes as well to this lateral cord. So the musculocutaneous nerve is supplied by C5, C6, and C7. Let's go now into this area. We find all of our non-terminal branch nerves. Okay. We have the upper subscapular and the lower subscapular nerve, as well as the thoracodorsal nerve. Another name for the thoracodorsal is the middle subscapular nerve. So there we would have an upper and a middle and a lower subscapular nerve. But I like to call it thoracodorsal because now we know where this nerve is destined. You guys remember what muscle the thoracodorsal nerve innervates? Yep, the latissimus dorsi. Very good. So that nerve is going to travel down alongside, somewhat close to the long thoracic nerve, which innervates the serratus anterior muscle. The thoracodorsal nerve innervates the latissimus dorsi muscle. Speaking of the long thoracic nerve, here we see the long thoracic nerve, which is really interesting because it comes off the rami, or the roots, of C5, C6, and C7, which is why we see C5, C6, and C7 here, to travel down, again, down the lateral thoracic wall to innervate serratus anterior. So, serratus anterior, there's a little saying that says, 5, 6, 7, which means C5, C6, C7. 5, 6, 7 wings to heaven. So in other words, if you lesion C5, 6, or 7, or especially the long thoracic nerve, if you lesion it, you get scapular winging. Okay. Going back to these subscapular nerves off the posterior cord, we talked about the middle subscapular nerve or thoracodorsal nerve. Well, we have the upper subscapular nerve, which serves subscapularis muscle, as well as the lower subscapular nerve, which also serves the subscapular muscle. So both the upper and lower help to serve the subscapular muscle. If you remember, it was quite large in that subscapular fossa. So it's going to take two nerves to serve it. And once again, it's innervated by only C5 and C6. Well, certainly you could think that C7 was going to contribute to those nerves. But interestingly, when they've mapped out the innervation of it, C7 doesn't contribute. Rather, this posterior division of the superior trunk brings innervation to the posterior cord to help serve the upper subscapular nerve and the lower subscapular nerve, as well as, in part, the thoracodorsal nerve. But you can see that C5 is missing over there. This is where things get quite confusing to students. So I'm going to try to simplify it a little bit. If we go back to the dorsal scapular nerve, the suprascapular nerve, the upper subscapular nerve, and the lower subscapular nerve, what do all these nerves / muscles that these nerves serve, what do they have in common? They're all controlling the scapula, and they're all very proximal, right? We're not talking about hand muscles at this point. We're only talking about the scapular muscles. So basically, I'm going to draw down here at the bottom, the scapula, the things that control the scapula are really C5 and C6. And I just said these are all proximal muscles. Now, what does the axillary nerve do? The axillary nerve innervates teres minor, which also is a scapular muscle, and it also innervates the deltoid, which, although it's not a scapular muscle, it's a very proximal arm muscle. So again, now I'm going to write the word proximal arm, and scapula is C5 and C6. So that makes it quite easy now that all these muscles that serve the proximal arm or the scapula are C5 and C6. There's the only exception would be the thoracodorsal. So you can learn that as the exception, and that's C6, C7, and C8. Moving forward, we have other nerves. Well, we have the radial nerve coming off the posterior cord, and that's all I'll say about that right now, but it's an extremely important nerve that's going to serve a lot of extensor muscles in the arm and forearm. We have the median nerve, which is going to also innervate distal muscles only, particularly forearm muscles and thumb muscles. And these are going to be in the anterior compartment of the arm. So this was a posterior compartment. This is an anterior compartment. These compartments will be more familiar at the end of the lecture. And then we have the ulnar nerve that is also going to serve the anterior compartment. So if you notice, the ulnar nerve really comes from anterior divisions. The median nerve really comes from anterior divisions. That's hard to see from all the scribble now. The radial nerve comes from posterior divisions. So anything that's served posteriorly is going to posterior compartments. Anything that is serving is coming from anterior divisions, serves the anterior compartments. And this is also an anterior compartment over here. This comes from an anterior division. The axillary nerve is a little more difficult because it's serving the deltoid and the teres minor, and that's not really in an anterior posterior compartment. Okay, moving on. Let's take a look at the lower picture in this slide. It's essentially the same pictures we saw up above, just looks a little different. But distally, when we look at these terminal branches, I want you to notice this green M. This is going to be important when we go into the cadaver lab to try to locate the brachial plexus in a dissected cadaver. For instance, where is the M on this picture? I just showed you the M on an illustration. That was on a brachial plexus that was mimicking a right brachial plexus. And this is a right brachial plexus. Do you see an M? Okay. The midpoint of the M is about right there. Okay. Let's go forward. And now you can see that midpoint of the M right there. And if we look again down on this lower panel, I'll draw it in, you have that M there. So it's important to find the M. When you have found the M, the most lateral branch of the M is musculocutaneous nerve. The middle portion is the median nerve. Median means in the middle. And the most medial portion is the ulnar nerve. Okay, the musculocutaneous, the median, and the ulnar nerve. So when you find the M, you can then isolate 3 of your terminal branches. So what's all this talk about compartments of the arm and the forearm? Well, here we see a picture of the arm, and here we see a picture of the forearm, or at least the cross sections of the arm and the forearm. There are 2 divisions or compartments within the arm. We have an anterior compartment and we have a posterior compartment. Similarly, in the forearm we have an anterior compartment and a posterior compartment. And to review, the anterior compartment is served by anything that came from anterior divisions of the brachial plexus. Anterior divisions of the brachial plexus. Either of the posterior compartments are served by nerves coming from posterior divisions. Okay. Specifically, the radial nerve. And then this one up here, we have 3. We have the musculocutaneous, we have the median, and we have the ulnar. All 3 that came out of that M that we just previously saw. All right, so we have some clinical correlates here. Imagine someone lesions their upper trunk. Now, what is the upper trunk? Remember, C5 and C6 merge together to form the upper trunk. So this is the upper trunk. So how would that occur? Well, anytime the head gets pushed, like we see in this picture here, the head gets pushed in this person to his or her left, looks like to our right, but it's his or her left, and the arm or the shoulder actually gets pressed that way because it hit a solid ground. Or in the case of a baby, you pull the head that way, but the arm gets stuck that way. Where you place tension here somewhere at C5 and C6 get tension in one direction, but the distal end of the nerve is being pulled in the opposite direction. You can get an upper trunk lesion. So this generally is called an Erb's palsy. So this can happen in adults like we see, or in obstetrics during delivery, especially difficult deliveries or large large babies who are coming out that that can get stuck for various reasons. So in a baby, you might have a pathology where there is posturing in a way that the distal muscles are working, the distal flexor muscles are working, but the extensor muscles here on the posterior forearm are not working. Also, the arm is going to be postured to the side of the body because the C5, C6 nerve roots are either damaged or the upper trunk is damaged, so we lose C5 and C6. Well, we were just talking all about how C5 and C6 serves proximal muscles plus scapular muscles. So those are the muscles that would be out. When I say out, meaning they are going to be weak or have the inability to contract depending on the severity. Meanwhile, the more distal muscles, especially in the extensor department, will be in the flexor compartment will be still capable of contracting. In similar fashion, meaning that there's a trauma or obstetrics, the lower trunk can be lesion. Well, this is a little different mechanism. Here, again, now we have C8 and T1 that come together to form the lower trunk. And in this case, you have a situation where the arm is going up and the body is going down, or the arm is getting pulled out and the body is staying where it wants to stay for some reason. And now you lesion C8 or T1 or the lower trunk, which causes weakness in the some of the extensor muscles and some of the flexor muscles in the hand, especially. So we get what's called a claw hand deformity. The last significant mechanism of injury is, or actually diagnosis, I should say, is the thoracic outlet syndrome. And this has many mechanisms of injury. But it can happen in 3 different areas. It can happen where the nerves come out of the scalene muscles, the anterior and middle scalene. It can happen between the first rib and the clavicle. And it can also happen what's called in the subcoracoid space. And I apologize. This says, I just noticed, this says the P minor. That should be the pec minor. That's a bad misspelling on my part. So in the interscalene triangle, again, we have 2 muscles here, the 2 scalenes, and the rami, or the roots, or the trunks could get lesioned in this area. And this is particularly common with people who have built up or have hypertrophied muscles, or especially in people who have respiratory problems, because their scalenes are accessory muscles in breathing in, and the anterior scalene is pulling up, the middle scalene is pulling up, and as a result they get larger, and that compresses on the nerve. In the costoclavicular mechanism, we have this chopstick issue here, where we have the clavicle and we have the first rib, and for whatever reason, this clavicle and first rib approximate or come closer together, and in the process may cut off the subclavian artery or part of the brachial plexus. So obviously we're talking about the brachial plexus here. This is a big issue where people might have some weakness and some sensory issues down in their upper extremity. In the case of the pectoralis minor, again, someone with a very tight pectoralis minor might cause some more tipping of the scapula, and in the process now we have a structural deformity where, and we don't see a picture here, but the coracoid process starts to impinge upon the nerves, or the pec minor itself starts to impinge upon the brachial plexus, but further down in the brachial plexus, closer to the trunks or the terminal branches, terminal branches. So most of the time we have a neurogenic component. Now when you look at this clavicle, if you look at this here, it looks like you'd have a major compression of the artery. But note, through that scapular anastomosis that we talked about last time, that the blood can reroute if this progresses over time and the arteries are given sufficient amount of time to dilate and bring the blood in a different form or fashion, a different route. But a nerve doesn't have that luxury, and so when it gets compressed here, it gets compressed and we can get some nerve death or at least disruption of the nerve transmission. Thus, we have 95% of the time we have neurogenic symptoms, meaning that the nerve is affected. That concludes this lecture. Please let me know if you have any questions or concerns.